Support for UWTV is provided by the Boeing Employees Credit Union.
So the topic for this conversation, you'll hear something in me. I long to be interactive. The worst thing I do or did for many years was a didactic lecture to medical students. So I try very hard not to make lectures didactic. So I'm going to ask you to be interactive. It'll be quietly interactive until the end. And so this will be a little bit hard. So you'll feel me, that sort of frustration occasionally. This is about assessment competency in the healthcare workforce. So we're all healthcare workers. What do the data tell us? One thing that Mike didn't say about me is that I was a lab technician for 6 years through pre-meds in medical school. So that's how I got through medical school, was a lab technician. And based on this warm feeling that I had for the laboratory, I did pathology for 2 years and loved pathology, but for a variety of reasons elected to become a family physician. The pathology always served me very well, and certainly the years as a laboratory technician, technologist in the end, served me very well as well. So these are conversational points, and I want them to be used in that way for your own internal conversation about competency assessment. And I have several points to make that fit. So this is a CME, Continuing Medical Education Accredited round. And for those of you that have been involved in CME in quotes before, you know you have to have learning objectives. So here are my learning objectives. You can write them down if you wish, or memorize them, or totally forget them, because we'll come back and we'll use them at the very end. So at the end of these rounds, each one of you will be able to define self-assessment, to identify the health profession that has most difficulty with self-assessment. Just think for a minute of all the health disciplines. Which one do you think has the most difficulty with self-assessment? List 3 forms of external or objective assessment. Apply this new knowledge to your own work setting, so Monday morning or tomorrow morning or tonight at 5 o'clock when you go back to your laboratory. And say this word, T-O-R-O-N-T-O, because I don't want to give it away, like a native. Not like a native Canadian, like a native person from that city. So those are the 1, 2, 3, 4. There are 5 learning objectives, and they're all easily accomplished, and those of you who know CME will be happy to know, very measurable. So this is knowing when to dab. I know that the coffee outside is not enough to keep you going. I also know it's late in the day. You've been busy all day. So when you hear summary and wrap up, it's time to wake up, aka the outline. So part 1 is this question. What is the evidence about self-assessment? What do you think about our abilities, health professionals, maybe physicians particularly, ability to assess their own performance, competence, the perception that others have of them? What do you think? Part 2 is if self-assessment is not so hot, and maybe it's not so hot, what other avenues for assessment are open to us? Is there a framework we could use just to kind of hang our hat on? Part 3 is so what? So what does this mean for us? And what I'd like us to wind up with, apart from the fun we're going to have along the route, is towards a better system of assessment and professional development. And I've got a couple words of summary and some pictures of my grandchildren. So this is the part that was meant to be interactive, and I'll ask you to think about this individual later. So this is Dr. Amit Kapoor. He's a 38-year-old anatomic pathologist, the director of an inpatient lab service, trained in India, in the UK, United Kingdom, and the United States. You can picture him, if you wish, sitting with his department chief or chair. And during an interview, a year-end interview, he outlines his professional development activities. So based on his own self-assessment, and a little bit of new hospital clinical developments, he's undertaken professional development courses in 3 areas: in renal path, new technologies in cytopathology, and a short faculty development course because he was nervous teaching third-year medical students and wanted to improve his skills. So what do you think of this? What do you think of this approach? So not only what he did for his professional development, but the process, this sitting down once a year with a chief or a chair. What do you think about that? And maybe as importantly as what you and I might think, what does his department chair think? And how else might we assess, here's the big question, how else might we assess his professional development activities? And how can we compare these to his competence and to his performance? So with that as kind of the scenario, the case, and you don't have to write anything down because I'll come down to the very last slide or close to the last slide before the grandchildren, is this again. And so we'll come back and we'll visit it. So here are some answers to the question, can physicians and maybe others self-assess? I will say there's a very large literature on health professional self-assessment and on physician self-assessment. And I expect an even larger literature that I don't know as well on humans, graduate students, self-assessment, the ability to gauge our own activities. What I decided to do with the colleagues whom you see listed here is to do a systematic review of the literature of those studies that compared some means of internal assessment, self-assessment, with external assessment. And I'll tell you a little bit about that. My colleagues are listed here. I'm grateful to the association which subsequently hired me because it paid me to spend a few weeks with them under a program called the Petersdorf Scholarship Program. And I have a colleague at McMaster University, the very last individual named, who also helped me craft this paper. This is in JAMA 2006. So here I'll just briefly describe the methods to you. I think it's of interest to look at the process of systematic review for all of us. So we did a pretty wide, we spread the net pretty widely. PubMed and Embase and CINAHL and the Research and Development Resource Base in Continuing Education for the last 40 years, and used those studies which compared the self-assessment of physicians with some external objective assessment. And because I was really interested in physicians and how they assess themselves, we looked at residents training, graduate physicians training, or practicing physicians, and each study had to have 50% or more. And we looked because the training methods were similar and the recertification methods were similar for physicians in the US, Canada, Australasia, and the UK. We just looked at those 4 countries or 4 jurisdictions. And we excluded something called self-assessment programs. In medical terminology, the self-assessment program is an online or paper-based program of multiple choice examinations with feedback. So we didn't look at that. And we didn't look at any quality improvement or educational interventions. This was just the ability of physicians to assess themselves. So the self-assessment was done by questionnaires or surveys or checklists. And the outside assessment, outside the physician in this case, external, were objective, structured clinical examinations or OSCEs. And if there's questions about those, I'm happy to take them. Standardized patients, examinations or written examinations, multiple choice examinations, simulations, chart audit, and interviews. And there were 3 broad domains. One was general medical knowledge. What do you know about what do you know about congestive heart failure, for example? One cluster was around the management of specific problems. So 2 that occurred to me to mention to you were dementia and palliative care. And there were broad competencies that you and I might call non-clinical, but have an impact at the bedside. And they were cultural or linguistic competencies, EBM or evidence-based medicine, how much critical appraisal skills do you have, and teaching competencies. So they were not directly clinical competencies, but I think we'd all agree that they were indirectly related to clinical care. So one example would be asking people in the audience, how well do you think you can pronounce this word like a native, and asking you then to score it. Perfectly, pretty well, probably not at all, never heard of that place. I chose a picture of that place incidentally because it had a little mist that morning. And I thought it resembled Seattle in some respects, just because it was on the water and had that sort of gray look to it a little bit. And it had a needle, of course, too. And then comparing that self-assessment to somebody saying, okay, so say it, and I'll evaluate you. I come from this city, and I'll evaluate you. So think about how you would pronounce it. And in the end, we'll have a little game. So here are the results. There were, for any of you who are embarking on a career of systematic reviews, think twice. My wife complained about my dining room. There was a while where we had several clusters of papers, and they filled up the dining room chairs. And at Easter, she said to me, "Do you think we could sit down at Easter for Easter dinner?" Which prompted a more thorough review and a more immediate response. So we looked at 1,000 studies, if only the titles of the 1,000 studies and subsequently the abstracts, and 17 met all the inclusion criteria. It was interesting. 6 of the studies were predictive. How well do you think you're going to do on an examination? And then how well did you do on the examination? 9 were kind of summative. How well do you think your patients assess your cultural linguistic skills? And 2 were concurrent. So identify your current learning needs, for example, and then comparing them to real learning needs. And the population studied, 7 of the studies were practicing physicians, 9 of them were resident or training physicians, and 1 was both. And there were 20 comparisons between self and external sources. I always want to make a drum roll happen here. But these are the results. Of the 20 comparisons, do we have a drum? Do we have a? No. So here are the 20 comparisons. 7, here's the good news, for those of you who believe that physicians can self-assess, demonstrated a positive relationship. Examples are cultural linguistic competencies, global performance with dementia patients, and comfort in family medicine with psychosocial issues. That was interesting. But here's the bad news. 13, more than, well, 2/3, demonstrated little, no, or here's what's scary, an inverse relationship between self and external assessment. So learning needs, critical appraisal skills, simulated knee injections. I don't know whether you can see this last little piece or not, but there's a inverse relationship between some physicians in a course that was labeled Know How to Do Knee Injections Better for primary care clinicians. And so they asked the clinicians before they took the course how good they were at this skill. 25% of the physicians said, we think we are really good, and turned out to be not only fair, but terrible. And what's even scarier is they didn't improve a lot at the end of the course. That's a separate paper. So just in case we missed the point, for those of you who have a more, so that's the text. This is the diagrammatic representation. This big green thing is those who didn't do so well. 7 who demonstrated a positive relationship, shown in purple or blue or something, and 13 that demonstrated it all. So that's kind of the bottom line. But it's true across health professions and health disciplines. Some of you were hoping I'd say surgeons were worse than family physicians or psychiatrists. The truth is we don't know, but we do know that it's probably a failing of all of us. So this is college students in their 3rd and their 4th year, asking them to assess themselves prior to taking an examination on grammar. And this is across the board. These were liberal arts and geography students and mathematics students. How do you feel you're going to do on grammar? And then giving them a test. And their perceived scores, everybody perceives themselves to be average. So that's the yellow line. So about 60 to 65, 70% is what I'm going to do on the examination. And in fact, this is a bell curve world. So 1/4 in the bottom quartile, no surprise, and 1/4 in the top quartile. So there are many questions here for all of us, I think. Among them is, and maybe there's a myth of self-assessment for us all. So it isn't just health professions. There's a reason why we need something called feedback. And this is a little piece called feedback. We may think we're not speeding, but in fact this poor turkey was doing 167 miles an hour. Scarier if this is Canadian, because that's 167 kilometers an hour, but it's not. It's miles. So maybe self-assessment is for all of us, is an issue. So that leads us to this question. What's a broader framework? So what's a guy to do? If self-assessment, if Dr. Kapoor, sitting with his department chair or chief, isn't really able to say my professional development pattern matches my needs, what are we to do? I mean, what are we to do as colleagues? What are we to do as healthcare workers? What are we to do in teams? What are we to do in the laboratory? So I'm just going to give us a little bit of a broader framework on which to hang the hat about assessment generally, competency and performance assessment, and even a few words about healthcare outcomes. I will apologize to you. This talk was derived mostly from the clinical realm, but I think there's a big overlap of the two footprints, and I think you'll feel at home with some of at least the comments. So there are 4 levels. One is perceptions or beliefs or opinions of the health professional. The competency assessment measures, I'll tell you a little bit more about each of these. Performance measures, and finally, patient care outcomes. So this is the continuum of assessment derived in large part from the continuing education literature, asking the question, so what happens at the end of a continuing education event or activity? So the first level is kind of like, what did you think about it? The happiness index. Did you like the speaker, and were the cookies good, and was the room warm enough? And what kind of topics might you like to hear more about? That's level 1, and we all do that. That's sort of, how do you like working here? How do you like your colleagues? Can you relate to your colleagues well? The next is competency. That's our knowledge, skills, or attitudes as tested not in the workplace, but rather in the test environment. So taking an advanced cardiac life support course and working on a resuscitation dummy, resuscitation, and then demonstrating competency on the dummy at the end of the course, that's competency. Similarly, a multiple choice examination. Level 3 is performance. It's what we do in the laboratory or the emergency department. It's what we do in the real world situation. And lastly, level 4, or healthcare outcomes. There is a little bit of overlap. I meant this slide, which isn't a very good slide, and I apologize for it. We can also ask physicians their perception about their performance, and there are ways in which we can ask that might get at some real-world measures of performance, and similarly about their competency. They are somewhat flawed by the self-assessment phenomenon that we've already talked about. So here we go. There are perception, beliefs, and opinions. We talked about 2 or 3 in the self-assessment review that my colleagues and I did, but there could be much better ways to get at it. So maybe a structured interview with fixed questions about what problems have you encountered in the last year. So again, I'm thinking of Dr. Kapoor. Could the department chair structure the interview in such a way to provoke some more conversation, at least internally in Dr. Kapoor's head, about what the real problems, real gaps in his care might be. So they could be structured interviews. They could be questionnaires or surveys. They could be generic. What do you think about the team you work with? Or they could be problem-based or topic-based. It could involve focus groups. There are dynamics in a focus group that we'd have to watch, but maybe a focus group of peers asking their assessment, not only of each other, but of the team function as a whole. We could throw out ideas to this focus group or to groups of peers, cases, problems, and maybe how can we solve this problem. And structured interviews I've talked to you a little bit about. Competency assessment, which if you remember is abilities tested in the test setting or the educational environment. They include multiple choice examinations. They include simulated problems. The OSCEs are, for example, a station with a patient who is short of breath. The medical student or resident or practicing doc is asked to go in and spend 15 minutes with a standardized patient to ask him or her questions about when the shortness of breath began, what its character is, to begin to work through in his or her mind what this might be and how he might or she might handle it. Paper problems are good at extracting knowledge, for example, maybe a little bit less skills. Simulations we've talked a little bit about, and Likert rating scale sort of on a 5-point, here's a discussion point. All women over 40 years of age should receive mammography free of charge, for example. Agree, strongly agree, neutral, disagree, strongly disagree. Testing attitudes towards, for example, access to free health care. Thirdly is performance measures. There's a large number of them. Again, they are more from the clinical realm, but they could apply here. Chart or case review and audit, utilization review, referral rates for primary care physicians, for example, pre-op orders, discharge orders, team collaboration. I'll come back in a minute and I'll talk a little bit about something called 360-degree feedback. Practical or clinical examination measures, like taking a blood pressure, for example, and something called chart-stimulated recall. It's sitting down with a physician saying, here's your chart, here's what you did with this patient in this encounter. What do you know about it? It looks like it's pointing to diabetes. The hemoglobin A1C seems to be elevated. What do you know about hemoglobin A1C? How frequently do you think the guidelines suggest that you should take it? So it tests not only performance of the physician, but also might test her competence. And patient and healthcare outcomes, I needn't burden you with all of these, but they are things like, is the hemoglobin A1C improving, for example? Do physical parameters improve with an intervention like blood pressures and weight? Maybe testing patient perceptions like patient satisfaction or pain. Pain scales are commonly used. We can also use provincial or state data, population health data, and levels 1 to 4, portfolios or places in which one might put performance, competency measures, continuing education activities as a learning measure. So that's the basket. That's the cluster of those measures which might be used if we believe, as I think we have cause to, that self-assessment is a bit flawed. But there isn't an easy button. This poor guy / gal, generic person on her computer is trying to find the easy button. I tried to find an easy button, by the way, and I couldn't download an easy button. So here are some specific lessons for assessment and professional development, just for your thoughts and for your input. And then we'll come back to that case and maybe tease that case apart. So here's the first lesson for assessment and professional development. Feedback is essential. So in the self-assessment literature, uninformed self-assessment is probably flawed. And I think all of us probably as colleagues and coworkers and maybe for ourselves need to request, even demand, a little more feedback about how am I doing. And the more specific, the better. The story I had among residents was when I trained family medicine residents, we'd let somebody go through a whole rotation. And there might be some problems in history taking or physical examination or short-term management, maybe interpersonal skills. But when asked generally how that resident was doing, we'd say, oh, she's okay. If they asked specifically about history-taking skills or physical examination skills or short-term versus long-term management, we might then have been able to say so. So the more specific the feedback, the better. And it appears to be essential. I'll tell you a little bit about planning for continuing education, something that you're involved in laboratory rounds, laboratory medicine rounds, and all teaching. I'm just going to share with you some ideas about can we alter traditional, I've called it CME because CME has a bad rap, sort of. It's this sort of thing where people are sitting passively in a room, and maybe we might be able to improve it if we built some feedback and some assessment into it. I'll ask you briefly what you think about undergraduate training, so how we train lab technicians and others, how we train medical students, maybe graduate students, and lastly, lessons for workplace assessment and maybe professional development. So this is the world of continuing education. This is the world that I came from at the University of Toronto and to a certain extent at McMaster, which is planning CME activities. So it's usually sort of 4 considerations. One is, what needs are there? So is there a need for this particular course or conference? One of them, what's the program going to look like? And the third piece is, what's the outcome? So what might we expect from the outcome? And lastly, what's the motivation? So I took a bad example, and I apologize to my clinician colleagues. So we would take a planning committee, sit them down and say, what do you want to hear about this year in the Hawaiian Gulf and Emergency Room 3-day program? So the planning committee would elicit its wants. The program was pretty much didactic, maybe 2 hours of lectures in the morning, skiing or golf, depending on where we were, and maybe an hour if it's skiing. It lent itself to a fireside chat / lecture for 1 hour of CME credit. And the outcome was pretty much a self-perceived change. Did you like the course? What particular aspect are you going to change in your practice, Mr. Rheumatologist? And happiness index. So did you like the chicken soup, etc.? And the motivation. What do you think the motivation might be? So resort location and speakers and credits. So welcome to the world of CME as currently structured in some ways, not entirely. Could we add something to it? Could we add external assessments to the process? And if we did, what might it look like? So maybe the planning committee wants would be replaced by some triangulation. Maybe subjective wants or needs are probably important, but maybe objectively assessed needs as well. So what is the performance measures we might want to look at if it's an orthopedic surgeon? What are the performance measures, like infection rate or recovery rates or length of stay in hospital, or etc.? And what are the barriers to improving your performance in this area? Is it competence, or are there some barriers external to you? So figuring out what the needs are better using assessment. The program might be better if there were more interaction, in order that you and I could talk, so that I could figure out what you know, so that you're my benchmark. So just think about that for a minute. If we're truly invested in team learning, we learn from each other partly by the standards that those others set. And there are other methods as well. We'll come back and we'll talk about them. And the outcome might be those levels. It might be competency change and performance change, and maybe even healthcare outcome. And maybe the motivation in time would change. Not that we're going to give up on the golf and resort courses in Hawaii tomorrow. You'd be glad to hear entirely. But maybe it's demonstrated competence and performance, and maybe even healthcare outcomes. So that's a little bit of an idea for us of continuing education. What about undergraduate and graduate training? So forgive me, this is a pretty medical example. From admissions to undergraduate medical education to postgraduate or graduate medical education to CME training, and it could involve postdoc training as well. You can imagine the continuum, and you know that continuing education is the most important piece because it's the right-hand side and it goes on forever. But maybe there's some things, maybe, here's a question for us. Are there personality traits which predispose to poor self-assessment? For example, among those college students who said they were better, among those docs who said their knee injection skills were superb and really didn't alter even when given feedback, are there some personality traits that are immutable? And maybe we should be screening for those at the admission stage. And are there generic tests of self-assessment ability that we might begin to employ? Here's a question for you in undergraduate, graduate training, postdoc training, maybe even post-professional training. What curricular strategies might we apply? Reflection, maybe learning portfolios, maybe encouraging people to maintain portfolios of problems they've encountered, of learning activities that they've done. And what assessment strategies might work to promote self-assessment? So could we begin to ask a group to assess how they've done prior to getting results back on an examination, so that they can begin to say, you know, I generally under self-assessment or over self-assessment. Assess. What is it that we can do? And I want to point you to something, those of you who are interested in something called Guide to Good Medical Practice USA. I had a little hand in crafting this with some of my colleagues at the association. It's a guide to show some of the exemplary characteristics of the best of at least physician behavior and maybe health professional behavior. And it includes things like the ability to reflect on one's past activities. Here's something in the workplace. This is called 360-degree feedback. You can read this just as well as I, but the notion here is asking our colleagues, our peers, our supervisors, and those of us who work clinically, our patients, to give us feedback on a variety of dimensions. Communication skills, for example, professionalism, ability to communicate new information, ability to provide a resource when asked, and using that 360-degree feedback to determine, at least in those areas where the peers or others can assess our performance, to therefore use that as a form of feedback on our performance. Sometimes it can be used in some organizations for promotional or pay decision, sometimes called 360-degree review. I'd be really interested in your comments on this. So this is the case for Dr. Kapoor, and what I think I might do is just conclude with a couple slides and then come back to this and use this as the prompter for discussion. So forgive me, I'll come back. I meant to put this right at the very end and I didn't. So here's the deal, guys. So do you think you can pronounce this word like a native perfectly, pretty well? Probably not. Not at all. So just assess yourselves momentarily, briefly. Just think I can do it? All right, hands up those who think it's pronounced Toronto, or compared to those who think the other way. So hands up for Toronto. Toronto, that's the majority of. How many of you think it's Toronto? Ah, good. And there's a Canadian in the background there who knows for sure. That's cheating, though. So that's about right. About 2/3 of you screwed it up. And but you see, you would have no opportunity for feedback. I mean, where in God's green earth, except for Toronto, would you ever get feedback, right? So it is, in fact, Toronto. So here's the summary of the talk. We'll come back and talk about the case. Well, we're, all of us, it turns out, sorry to disappoint those of you who thought it'd be surgeons that would be poorest at self-assessment. I thought it would be surgeons, but not so good at self-assessment, though we use it all the time in CME, at continuing education, and maybe elsewhere. I think we use it pretty universally. There are objective measures and tools. Among them is this one, 360-degree review and feedback to gauge performance. And there are lots of implications here for continuing education and for training, undergraduate medical education, graduate medical education. There's lots of implications, I think, for workplace performance management and improvement, and for professional development. And to help kickstart the conversation, let's go back to Dr. Kapoor, and I'm more than happy to take your comments and your questions and thoughts. And did I put you all to sleep?
You want us to comment on what we think about the Dr. Kapoor case?
You can comment on anything you like. Dr. Kapoor might be a kickstart for you. So let's start with him if you like. I don't see any burning questions in the audience. So
I do have one
yes, Mike. I'm not surprised.
Talk about if, on average, I think what you're saying is that we shouldn't trust a person's self-assessment. They're as likely to be self-assessing poorly as they are or accurately. So what are the implications for patient safety with regard to how we handle human resources?
That's a very good question. I'll repeat the question if I may. So what are the implications for the fact that we are poor self-assessors for patient safety? So I think if we asked ourselves there are 2 or 3 points to make. The first of them is if we ask ourselves the question, or if we ask a team of people, how do you think you're doing at patient safety issues? Do you understand them broadly, and do you think you're applying them widely? I think we'd probably get nods around the room. Yes, I think I get them. I mean, we should be safe, right? So I think the first point to make is we need to be specific. So we need to ask specific questions. Do you know about this particular instruction in an item labeled possibly infectious or something? So I think we need to be very specific. I think the other thing to say is that we probably shouldn't trust the self-assessment and need to develop some objective measures. And the third piece is we need to give people feedback. So if we've developed some pretty specific patient safety measures and we've been able to assess them, to look at them, and then feed back to somebody or a group of individuals, 79% of the time you guys are doing fine, but on, 21%, you're not doing so well. I think that would be very helpful. So those are 3 take-home messages about anything, but I think particularly about patient safety and quality improvement issues. So I think we all think we've got the bigger picture here. Yes, sir.
When I was the chief resident of this program in laboratory medicine, I met with one time the director of the hospital, the dean, and they were interested in, it was a meeting with all the chief residents, and they were interested in beginning to try to figure out how to do outcomes-based sort of assessment of resident practice. And I chimed in sort of from the back and said, well, how does that address laboratory medicine residents? But then they admitted they hadn't even thought about it, that we were sort of just ignored in that thing. And the question becomes, if Dr. Kapoor had been a laboratory medicine resident, and this had been happening, could we figure out if a self-assessment for Dr. Kapoor was not adequate, is there an outcomes way to assess performance of laboratory medicine and pathology residents? Because we are consultants and not direct care providers.
Yeah. So I think there are lots of measures that we can apply, but let me repeat the question first if I have it. So are there measures of performance for laboratory medicine residents and laboratory medicine practitioners or specialists? I think that's the question.
based.
Yes. So are they patient outcome based sufficiently? I would have to turn to you to say, I don't think so, because you're not direct clinical care providers. But there are distal outcomes. So a missed diagnosis would have significant distal outcomes. So I think we need to kind of keep that in the framework. But there are some competency measures that we could think about, I expect, and there are some performance measures I think that we could think of. And maybe I'll turn it, rather than me listing them, not knowing the field as well as I might, 30 years ago I might have been more knowledgeable about it, but I would turn to you to say, what do you think good competency measures and performance measures might be for laboratory medicine trainees and practitioners?
As I was alluding to, I think that it's quite a different thing. I think it's not all that difficult maybe to assess competency. We have exam type thing to test databases. We have portfolios like you mentioned, and those sorts of things for residency training. But there is a difference, I think, between relating us directly to patient outcomes. But there seems to be a very big push now to really review people. I mean, payments even becoming graded on outcomes. And is it easy to do or fair to do for consultants, essentially radiologists or something like that?
I think you're right. I think it's harder to do. I think what we then have to do is shift when we talk about outcomes, what are reasonable outcomes for us as consultants, for example? So what might that look like for us? So a reasonable outcome might be effective, efficient diagnostic skills applied in the workplace, for example. And can we burrow down to say, is that quick sections in the laboratory, for example, or in the pathology lab, for example, is that a quick session with an appropriate diagnosis? But again, I'd have to turn to you guys. I've set some of the stage. And maybe in the conversation here afterwards we'd be able to develop them. Here, for Dr. Kapoor, I was thinking there might be some other things we might think of for this individual. For example, it looks like he's a director of a service division. Maybe the division chief wants to know, is he a good division head? Is he somebody with good interpersonal skills? What do his team think about him? Is he a good administrator? He's got to manage people. Does he have human resource management skills? Where might you turn to for that? That might be the 360-degree feedback. So if I were the department chair or chief, I would look at all the functions and look at what those outcomes might be. So happy, efficient, effective, well-run staff might be one example of an outcome I would look for. Yes, you sir first, then we got a few over here.
I have a question about teaching people how to do the 360-degree review, which I love as a concept and is being employed around the medical center in a variety of different ways, but occasionally some of the feedback has been, I guess, less than generous or perceived as colleagues who might be either rivals or kind of a confrontational, and it's because it's peer-to-peer, and sometimes the feedback has been provided in a kind of a less than, not very well filtered way. And I think, but part of the process is a problem is that people are not so familiar with it. We're still learning how to do it. So my question is, how do we train people to be reviewing peers? And are there some formal techniques or advice that, or kind of resources available for us to provide this in a collegial, peer-based, and with these funny kind of diverse relationships? So
just to repeat the comment, I think it's a very thoughtful comment. So what about the negative feedback and the response to the negative feedback in 360-degree review, particularly in a small team where I might be able to identify the source of the feedback for my own performance, for example, and could we train people? So could we train people in order to give more appropriate feedback? So most of the 360-degree reviews that I've been involved with, and one most recently at my association, has been a proprietary intervention. So if to name one over another, I'd be reluctant. But I think they all have several principles in common. The first is that they do train, and they train around a standardized case, so a little bit of a paper case. You've got somebody who's generally all right in your team, but she shows up a little bit late, doesn't always pull her weight, isn't always available for consultation when you need it, how might you provide this individual with feedback? And so in a conversational way like this, somebody might say, oh, he's an idiot, or he's a jerk. Well, maybe we could reformulate some of that. So there are some training modules that are available. The other thing is to make sure that we have a large enough N in the 360-degree feedback so that it's almost impossible for you to identify who the individual is. And it needs to have a moderator, so it would need the department chair or chief, somebody to be a moderator to say, that's an outlier comment. That sounds more like a personal comment. I have 9 good reviews and 10 terrible reviews. There must be something with this individual. Maybe I should speak with the individual to find out what the issue is, and it may just be a personality clash or something like that. So there are some modifying things. I think in teamwork, in things that others can observe, it's wonderful. But unfortunately, in medicine, as in all things, we take a tool and we make it kind of comprehensive. And so family physicians in Alberta, for example, are now being, all physicians are being evaluated on their competency by their peers. And I'm not always sure that peers can get inside the head of the doc, particularly if there's a referral or consultation bias involved. So I think we need to be thoughtful about the review source and the nature of the feedback and its goal, of course. There was a question at the back of the room, and then we'll go over here. How's that?
Well, just to sort of follow up Dr. Winter's question, so these evaluations are for some of the departments in our medical school, evaluations of clinical competency by colleagues are used as part of the evaluation of clinical skills for promotion, appointment or promotion in the academic ranks. And so is there data that says that clinical competency as assessed by clinical colleagues and peers correlates either with clinical performance as you define it or outcomes? In other words, is that a better type of competency measure than some of these other things like standardized tests or standardized patients or whatever it is?
Yeah, so here's the question as I understand it. Are there some measures of assessment, like asking a peer to assess the competency of his or her colleague, that are better than others? And do they match, as I understand it, do they match with performance measures? If there's literature in this area, I don't know it. So if I assess a surgeon's skill and then somebody else assesses by performance measures, quality measures, for example, how he does, I'm not sure, unless I work side by side with him, that I'd be able to judge that. So I'm not sure. I think the more objective, the better. I think if we're asking about communication skills or team skills or consultation or availability, I think those are things I can judge as, say, a referring physician, a family physician to a surgeon in a community hospital. I think I can judge those things. And I think I can judge a little bit of patient satisfaction if I've been the referring doc and I get the patient back. But I'm not so sure about the other measures. And I think for those, we better be as objective as possible. Yes, sir.
I have a slightly facetious question, but we've got a lot of laboratory technologists and a lot of residents and fellows we work with, a lot of clinical colleagues. Will we actually have time to actually do any performance of our clinical jobs if we're spending all our time evaluating everyone?
Yes, sir. So it's a very good question. So it's I had a cartoon I showed at noon today, and it's a guy in New York City, looks like New York City, and he's a Wall Street kind of guy, and he's on the phone, and he says, and he's got a date book in front of him, a calendar in front of him, and he says, how about never? Is never good for you? So this is the question of time, and I'm sorry I don't have it with me. So this is about the question of time. How time intensive is 360-degree review or any formal performance competency assessment? So I am the guy who groans when the 360-degree performance review little email comes around to my office. So I got a day full of phone calls and conferences and policy stuff and all that, just as we all do. Mine isn't so clinical anymore, so mine is less important, but I still really begrudge that time. But I will tell you that I've learned something. I've gone through 2 in this association, and I've learned something both times. 1, because I was new and needed to have some feedback, and 2, because it taught me something about the perception that others might have about my belief that I was a good team player, when in fact I might not be a good team player. And so I think my performance has improved as a result. So I feel a little more positive about it. I do think that it needs to, I think we need to be thoughtful about it and not say everybody has to get it all the time. I do think we need to be pushing back to the person who assesses himself or herself, just like Dr. Kapoor, and say, show me some gaps in care, show me some objective measures that you can collect in the course of your average day. So I think what we need to do is couple the assessment with our workload so it doesn't seem so bad. And I also think we need to show the value of it for all of ourselves. But it's a really good, it's a really good question. Other questions? I did see some hands up over on the right-hand side. Yes, sure, yeah.
So I agree with you that the ability to respond to feedback and change is a good attribute. And you mentioned perhaps screening people at the outset of their education. Can you just give an example of how you might actually achieve that in a mutually agreeable way?
Yeah, so here's the question about and I think the broader question is self-assessment a characterologic kind of personality issue? So in my naive mind, and could we screen for that? So the first day of medical school, no, before the first day of medical school, in the admissions, right? So today, I think, was medical school application interviews. I went in to see Tom Norris at 10 o'clock or something. There was a whole bunch of students in ties, so I knew they weren't real medical students yet. They were very neat, and I was very impressed. And for 4 years, they won't wear a tie until it's graduation, and then we'll wear ties again, right? So I smiled because they were just like my own experiences. So the question for these people might be, can we determine, are there tests that we could do that look at their abilities, self-assessment abilities, and rate them against some other objective measure? I'm not sure how we do that. There are two scales about self-reflection. One of them is the ODI scale, ODDIE. One is the Di-Giannomenico scale. So they were used in college students, but the problem with them is they're content specific. So I'm not so able to rate myself in something that I'm not so familiar with. So if I'm a typical college student in liberal arts, I might think I'm pretty good in history and maybe not so good in philosophy and not so good in something else, because I know a lot about history, and so I can assess myself better. So I believe that there are some abilities that exist, but I don't know that we've defined them yet, and I'm not an educational psychologist, so I'm probably the last person in the room to be able to discuss them. But I'm thinking that we need to push our way that way. I, for many years, had something to do in the province of Ontario for remedial education. And there were physicians who were significantly disabled in a competency sense. And it probably began in medical school and fairly quickly deteriorated. And they would come to the attention of the provincial licensing authority, and they'd wind up as a CME professional. They'd wind up in my office. And it seemed to me that many of them were, there were a handful, that several of them could not be saved by educational experiences because they believed they didn't need it. It was the world that was wrong, not them. So they're probably the outlier. They're probably the 1% or 2% that are on the bell curve sort of lying out here. But I'd like to screen for those people earlier if we could, and I think that's one way to do it. I just don't know what that test would be. Other questions or comments? Yes.
Yeah, I just wanted to mention the clinical skills exam that was implemented for medical students maybe 4 or 5 years ago. Are you aware if that's made any difference on predicting if residents are going to succeed in their residency?
Oh, that's a very good question. Thanks. It's this is about the penultimate clinical skill examination in medical school. Has that made a difference? And I don't know whether it's made a difference or not. That is, in outcomes in residency or beyond, I don't know whether it has. My assumption would be what it's done is to bring us all up to a level, all the medical schools in the country up to a level of competency, maybe baseline competency, in the teaching and demonstration of clinical skills. So I think for those schools that didn't have such a good clinical skills curriculum, I think it's improved the schools, and I think anecdotally that's the case, but I don't know if there's any evidence that it's had an impact beyond.